Dr. Clark has created quite a buzz within our membership in that he'll be talking to us about a topic that's new to many of us, and that is the mind-body approach to chronic pain. He's president of the Psychophysiologic Disorders Association and teaches graduate courses on psychophysiologic medicine as a faculty associate at Arizona State and at the Cummings Graduate Institute for Behavioral Health Studies. Other impressive academic credentials include assistant director at the Center for Ethics and clinical assistant professor of gastroenterology emeritus, both at Oregon Health and Science University. Dr. Clark's written a book for patients titled "They Can't Find Anything Wrong," which I think many of us can relate to that title. And that is available through Amazon in either paperback or Kindle editions. And he was also lead editor for the professional textbook, Psychophysiologic Disorders. He's lectured extensively and appeared on more than 100 television and radio broadcasts. As a practicing gastroenterologist in Portland, he diagnosed and treated over 7,000 patients whose symptoms were not explained by diagnostic testing. And as Bill said, as Dr. Clark talks to us, feel free to enter your questions in the chat box and he'll address them following his presentation. But you might want to address them ahead of time so you don't lose track. So I know that we're all eager to hear how psychophysiologic research might apply to at least some of us with peripheral neuropathy. So without further ado, I'm going to hand the program over to Dr. Clark.
Well, thank you very much, Bill and Joanna. It's a pleasure to be here and to have an opportunity to share some ideas with you. And whenever I speak to the public, I think it's important to recognize that for some of these ideas, they won't apply to you, that the peripheral neuropathy is caused by diseased nerves and is not in any way related to the topic I'm going to discuss today. But for other people, the information I'm going to present will be new and highly relevant and in many cases life-changing for the better. So there's quite a spectrum. And even for people that the information is not personally relevant, it may give you some insights into people who are close to you or people whom you know. So I'm hoping one way or another you'll find this material interesting. Let me get my slides going here. Can you all see Pain from the Brain?
Yes.
On your screens? Okay, very good.
Good shape.
And this is one of the key insights that most people, members of the public, and even many healthcare professionals are not fully aware of, which is that the brain can generate pain. The brain is, of course, the place where the sensation of pain is actually felt. You know, if we whack our thumb with a hammer, we are feeling that sensation in our brains. But in addition to feeling sensations that are coming from the periphery in our body, the brain can also generate pain. And the classic example of that is what's called phantom limb pain, which occurs in someone who's had an amputation of an arm or leg, and yet they feel pain at the location of that missing limb. And obviously the pain is not being generated by that missing limb because it's not there. The pain is being generated by the brain. And it turns out that people who have all of their limbs can experience this central pain as well, or brain-generated pain. Here's another example of that. This was an image that was published in the British Medical Journal in the mid-1990s of an unfortunate man on a construction site who jumped down from one place to another and got a nail right through his boot, as you can see in the illustration there, or in the photograph. And he was, instantly in agonizing pain. He was rushed to the emergency room. He was given morphine intravenously to alleviate his pain. And then the boot was carefully cut away, only to reveal that the nail had passed neatly between his toes and had not caused any tissue damage at all. So just the mere sight of this nail going through his boot had been sufficient to cause the pain, even though his foot was perfectly fine. And of course, as soon as he saw this, his pain was instantly relieved. But it's a great story about the capacity of our brains to generate physical symptoms, pain being the most common, but it can generate other symptoms as well in conditions like irritable bowel syndrome or ringing in your ears, lots of other sort of non-pain symptoms as well. So the next question that comes up is, how do you know if you have this going on? Because you can have this all by itself, central pain or brain-generated pain. You can have this in addition to other conditions. You can have, for example, arthritis, but also central pain at the same time. You can have peripheral neuropathy causing pain, but have brain-generated pain at the same time. So there, unfortunately, is no definitive diagnostic test that can tell us with absolute certainty whether a person has central pain or not. But there are clues that we can use to build a progressive level of certainty about whether central pain is going on or not. And the first of these clues is that symptoms are not typical. If you've got, absolutely classic, let's say Charcot-Marie tooth, for example, and your neurologist is telling you, yes, this is, absolutely what you have, you're a textbook case, then the chances of your having central pain as a contributing factor are a lot less. If you have many different symptoms in addition to pain in a peripheral location, for example, if you've got symptoms elsewhere in your body, if you've got fibromyalgia, if you've got irritable bowel syndrome, if you've got bladder spasms, if you've got migraines, if you've got back pain, the more symptoms you have, the more they are varied in their locations and in their nature, then it's more likely that central pain is occurring and is contributing to your overall illness. I forwarded a questionnaire to Joanne Jessen, who was kind enough to post it on your website. I think it's 37 questions at this point. It's recently revised, and it's set up in a way that the more of those questions to which you answer yes, the more likely it is that you have central pain going on. Next concept that we look for is, do you have sufficient stresses in your life that are capable of causing central pain? There are certain life stresses, situations, past histories that those of us who work in this field typically look for. And the more, and we're going to go over those in some detail shortly, and the more of those that you have, the more likely that central pain has been generated by them. And then finally, if we can uncover the stresses that are likely responsible for central pain, we can almost always treat those stresses and make them and alleviate them to a certain extent. And if we do that successfully and the physical symptoms, pain or otherwise, improves in response to that treatment, then we've got very good circumstantial evidence that central pain was happening. And when we completely alleviate the physical symptoms, that is our confirmation that central pain is what's going on, because you can't alleviate peripheral pain just by talking to somebody and alleviating their symptoms, but you alleviating their stresses, but you absolutely can alleviate pain by that's centrally mediated, centrally caused, brain generated by alleviating stresses. So if you have central pain or brain-generated pain that is linked to psychological or psychosocial stresses, then my colleagues and I refer to that condition as a psychophysiologic disorder. This is a blend of psychology and physiology, abbreviated PPD because it's a fairly long term. And it consists of central symptoms, pain or otherwise, caused by past or present psychosocial stress, and typically not associated with abnormal organs or structures. For example, if you've got an abnormal nerve conduction test, it makes it less likely that your pain is connected to the brain. But even some people with an abnormal nerve conduction test can simultaneously have brain-generated pain. So it's possible to have both at the same time. But you'll hear me use the abbreviation PPD fairly often. And again, signifying that blend of psychology and physiology. And we're going to talk about the psychology in some detail. Let's see. These symptoms that are brain generated, or PPD, as I alluded to, can be present fairly widely in the body, literally from head to toe. And once again, the more of these symptoms that you have at the same time, the more likely that brain generation is involved. And again, migraines, tinnitus, ringing in the ears, difficulty swallowing, visual disturbances, pain in the spine, either the neck or the low back, difficulty breathing, chronic cough, pain in the chest, pain in the abdomen, pain in the pelvis, bladder spasms, pain in the joints, a whole wide range of symptoms that can occur. And oftentimes the only common denominator in PPD is that more than one symptom is occurring at the same time. Fortunately, PPD is an illness with a solution, as I've alluded to. If you identify the stresses that are responsible and you treat those stresses, people can improve. Sometimes they improve slowly, and some of them need years of psychotherapy to make a difference in their symptoms, but other people improve dramatically quickly once the underlying stress is identified. And this is a favorite example of mine. It's the first case that I described in my first book. There's a 50-year-old woman with attacks of severe vomiting and dizziness that occurred somewhere between 6 and 10 times per year. About half of her attacks were severe enough that she had to be hospitalized. She lived in a community where there was a major university hospital, outstanding reputation nationally and internationally. And yet, despite being admitted to that hospital 60 times over 15 years, she had no diagnosis. They were not able to figure out what was going on. And they even had her see a psychiatrist after she'd been ill for a few years. And as is too often the case with mental health professionals, he wasn't familiar with the kinds of stresses that can make people physically ill as opposed to having mental illness challenges. And so he completely missed the diagnosis. But because of knowing what to look for, because of knowing to investigate for the kinds of stresses we're about to talk about, I was able to find a particular stress in her life that was directly linked to the attacks of illness that she had. And just in her case, bringing that stress into her conscious awareness, because so many people, you'd think if you had a stress capable of making you physically ill, you would for sure know what it was. But it turns out that's not true most of the time, that many people fail to recognize the magnitude of the stresses they're coping with. And that was completely true for this patient. She had no idea how much this particular stress was affecting her until I was able to show her how it was connected. And once she saw the connection, in her case, that was all that was needed. She never had another attack of her illness. She even called me a year later to say she'd gone the entire year with no episodes. So that brings us to the question of, well, how do we investigate this condition? What kinds of stresses should we look for? And how to do that is really nothing new. It's just kind of been forgotten by the healthcare profession. This is a quote from Francis Peabody, who was a Harvard Medical School professor who gave a speech in 1925 that was published a couple years later. And his speech was, to be honest, it's 6,000 words long. I've read the whole thing many times, and it's not all that different from the presentation I'm giving you today. So we've known about this. And my favorite quote from this is, in all your patients whose symptoms are of functional origin, which is to say PPD, the whole problem of diagnosis and treatment depends on your insight into the patient's character and personal life. But unfortunately, this concept has been swamped by the tsunami of technology that's overtaken healthcare in the last 100 years. And this simple truth, which applies to a large number of patients, has kind of been forgotten, but it's being remembered now with, I'm getting some feedback here. It's being remembered now with some new research that we'll talk about later. So how do we operationalize Dr. Peabody's insight? And the way I teach it is to do what's called a stress evaluation. And the stress evaluation has multiple parts, but it's basically a systematic review of all the different kinds of stresses that are capable of making people physically ill, pain or otherwise. And it starts with the chronology of the illness. When and where did the symptoms begin, and what has been their pattern over time? And the reason it's important to know this is that once we have the chronology of the illness, we can look at the stresses in the patient's life and try to see if there are any chronological links. In other words, was there a major stress in the person's life right before their symptoms began? Or does the fluctuation in their symptoms to more and less severe connect in any way with stresses that are going on in the person's life? And we don't always find that. The stresses that are triggering fluctuations in illness may not be obvious, but when we do find a connection, when we do find that there's a stress to symptoms link, that gives us more confidence that PPD is what we're dealing with. So knowing the chronology is important. Here we go. I think I skipped a slide. There we go. The next part of the stress evaluation is just to look at stresses that are going on in the person's life at the moment. What kinds of problems and difficulties and stresses are happening right now? Has there been any connection between those stresses and the fluctuations in symptoms? And over the years, I've treated over 7,000 patients with this condition, and I've probably seen almost every bad thing that can happen to a human being connect to PPD illness in one way or another. So it's, one of my patients, just to pick a slightly unusual source of stress, was that, getting some feedback again, but what was happening to him was that his church was having a dispute over religious doctrine, and they were splitting. A large group of parishioners in his church were going off to form their own church because they were having this big battle over doctrine. And he was a deacon of the church, and this split in his parish was tremendously distressing for him, and it correlated very strongly with the duration of his physical symptoms. A subset of this is of stress going on in your life at the moment is insufficient personal time. And many of us experience this from time to time, but my patients who suffer from this the most are the kinds of folks that are taking care of everybody else in their world, but yet they struggle to put themselves on the list of people they take care of. So if these are people, if they've got 5 or 10 minutes of free time, they're not thinking about putting their feet up, pouring themselves a favorite beverage, grabbing a book they've been meaning to read. They're thinking about useful, constructive things or things that will benefit others. And when you ask them what they do for fun, they don't do a lot. They don't have a lot where they are just taking activities with no purpose but their own joy. And you can do that for a while, but if you were doing that indefinitely and you don't know how to put yourself on the list of people you take care of, then sooner or later it can catch up with you and start to produce physical symptoms. These are people with whose lifestyle is somewhat akin to being on a treadmill they never step off. And again, you can't do that indefinitely. Self-care, taking time for your own joy is an essential human skill. And then a big surprise to me early in my career was learning that stress when you were a child could make you ill as an adult. My very first patient, whom I encountered in 1982, had this issue. She had been severely abused as a girl between the ages of 4 and 12, and she became ill at age 35, and rather severely ill. It was seen in 2 different university medical centers with no explanation for her illness until the connection to her childhood stress was uncovered and was treated by a psychiatrist who was knowledgeable about those issues. And within 3 months, her severe physical illness was completely alleviated. So that was my introduction to this idea, and I subsequently found that it was an issue for a majority of my patients. And the common denominator here is treatment of the child that makes them feel like a second-rate human being in one way or another. And there are lots of different ways that you can do that to a child, knock their self-esteem down on a long-term basis. And more of this was clarified by a landmark study that was published in 1998 called the Adverse Childhood Experience Study by Felitti and Anda. And what they did was at Kaiser in San Diego, they had 18,000 people coming in for routine checkups, and they all filled out a computer-based questionnaire that included, among other things, 10 questions about childhood adverse experiences. You can see those on the screen here. It turns out that these are not the only 10 experiences that can cause problems for you later in life. There's a bunch more that have impacted my patients over the years, and those are on this slide. One writer has called chronic unpredictable toxic stress. And there's even more you could add to this list. So eventually, in the questionnaires that I used for screening my patients, I boiled all of this down to one question. And it's actually the last question on the questionnaire that I sent to Joanne Jessen that she posted on the website. But the question is, and I can see that it's off the top of the screen here, so you may not be able to read it, but the question is, how would you feel if you learned that a child you care about was growing up exactly as you did? And in my lengthier written questionnaire that I use to screen my patients, I give people a choice of 4 different answers to that question. And once again, the question is, how would you feel if you learned that a child you care about was growing up exactly as you did? And the 4 choices that I give are that people would be happy about that, people would be neutral about it, they would be sad or angry about it, or they would be very sad or very angry. The version of this question I sent to Joanne changes it so you can just say if you would be sad or angry or not. But if you take those 4 answers and correlate them with the full ACE questionnaire that was used by Felitti and Anda in their landmark paper, on the left-hand side of this graph is the ACE score for each of the 4 possible answers. And you can see that the less happy you would be about a child growing up the way you did, the higher your ACE score. ACE scores, I should mention, are the majority of the population actually has at least one of these, and about 16%, or one person in 6, has at least 4 of these. And people who have 4 or more of these childhood adversities compared to people who have 0 have much worse health outcomes as adults. People with 4 or more of these are more likely to be depressed, more likely to attempt suicide, more likely to use drugs, more likely to be obese, to have various medical problems, and just almost every bad health outcome you can think of has been studied now in relation to ACEs, and they're all much worse in the group that's had 4 or more. Fortunately, these long-term impacts can be treated. One of the challenges with this is that none of us has a parallel life to compare with, so that many of my ACE survivors, when they look back at their childhood, they don't recognize just how challenging it was for them. And I've had many patients who actually went through a pretty severe experience when they were kids, who will at least initially tell me, things weren't that bad. Other people have been through worse than I was. I think I've overcome those experiences. So how do you tell if your childhood experience was bad enough to produce a long-term impact? And there are 3 different things that I look for. Number one, a very common long-term impact of ACEs are various stressful personality traits, and you can see these on the screen here. Low self-esteem being a very fundamental one. But the more of these personality traits that you have, nobody is typically born with these personality traits. They are acquired, and they are acquired in relation to surviving a stressful childhood. That in order to survive that childhood, you have to focus on pleasing others, focus on details, being perfectionistic, being highly self-critical when things go wrong, having unrecognized negative emotions. We'll talk about that one in a bit. Choosing bad partners for yourself as an adult. Many of my patients who are ACE survivors have a history of their adult relationships being not healthy for them. Living on high alert, self-sacrificing on behalf of others. Again, these are all grow directly out of surviving an ACE environment as a kid. There are more of these personality traits: difficulty setting boundaries, poor skills at asserting for your own needs or setting boundaries. There are some positive qualities as well that come out of this: being reliable, detail-oriented, compassionate towards others, and hardworking. And those qualities, stay with you as you recover from the ACEs impact. Another way to tell that you might have long-term impact from ACEs has to do with these emotions, negative emotions that are typically not recognized by the people who have them: anger, fear, shame, grief, and guilt. Sometimes they will come out. There'll be a sudden angry outburst that a person will have, and they'll be thinking that the trigger for that angry outburst seemed to be too small, that they should not have had an outburst of anger or fear in relation to what triggered it, but nevertheless they do, because these emotions are kind of like boiling magma inside a dormant volcano, that they're in there, but they tend not to show themselves very often. But nevertheless, these emotions can be, if they're not being expressed in words, they can be expressed via the body in the form of symptoms. And many of my patients have had tremendous amounts of these emotions directed at people they still care about. And so they keep the emotions buried, and the emotions then can, looking for a way to manifest themselves, they do it through the body in the form of symptoms. And then finally, there are long-term ACEs that can lead to responses to triggers, that there are certain triggers in a person's life that can lead to emotions, lead to physical symptoms. When those symptoms or emotions manifest themselves, we can see a connection to their past ACEs experience. So if you have something in your life that reminds you of an ACE experience, that can be a trigger for you and trigger emotions or symptoms. One example that a colleague of mine mentions in his lectures is a man who had a domineering parent, and in the course of his life, he acquired a domineering boss in his workplace. And the parallels between those two things were enormously stressful for him, and he developed physical symptoms as a result. Ironically, sometimes positive life events can be a trigger for symptoms or for emotions. If you have suddenly found yourself in a relationship with someone who treats you well, you're in a mutually beneficial relationship, that certainly sounds like a good thing, and it is. But if it's the first time you've been in a mutually supportive relationship, you may develop some anxiety about whether it's going to last. It also can trigger the idea that if you are actually worthy of being in a mutually supportive relationship, then you were probably worthy of that when you were a child as well. And that can stir up some of those negative emotions that we described earlier. And then finally, many of my patients are still in ongoing interactions and relationships with people who mistreated them when they were children. Now they're an adult, but the ACE perpetrators, we can call them, are still in their life and are stirring up a lot more stress than the patient is recognizing. So these are ways to tell that ACEs might still be having an effect on you. The last three parts of the stress evaluation are to screen for mental health conditions that rather surprisingly manifest physically rather than mentally in many people. Depression is a good example. It's pretty obvious you have depression if you feel depressed, and if you're feeling like your life is no longer worth living. But many people, even a majority of people with depression, don't have those conditions. Instead, they manifest themselves physically, often with symptoms that are difficult to pin down. And so in order to diagnose depression, you have to look for symptoms of depression other than feeling depressed, other than feeling your life isn't worth living. And those other symptoms can include not sleeping well, your energy level being down, your appetite being off, crying for little or no reason, losing interest in activities you used to enjoy. And when I ask people about those one after another, even people who say, nope, I don't really feel depressed, stressed out, exasperated, frustrated, really wanting this symptom to go away, whatever it is, they'll have all of those. But when I ask them about these other symptoms of depression, that's when I'm going to hear, yes, those things are going on. And that's going to clarify the diagnosis. Post-traumatic stress is another one that may manifest itself primarily physically. And you have to ask people specifically, have you been through a trauma? Have you been through a horrifying or terrifying event? And sometimes that event was right before the symptoms began. So there's a direct chronological connection between the occurrence of the trauma and the onset of the physical symptoms. And that gives you a lot of evidence that the two are linked to each other. In a few people, the trauma was remote. I've seen patients where the trauma was pretty severe, but it happened 10 years, 12 years before their physical symptoms that brought them to my office began. And what's going on in those cases is that some kind of triggering event happened right before the illness began, the physical symptoms began, a triggering event that is linked in some way to the trauma. So one of my patients witnessed her brother being murdered, and but didn't develop any symptoms at that time. But a decade later, she encountered her brother's killer in a store, and he had been released from prison, but nobody warned her that he was out there. So it came as a complete shock when she ran into him. Fortunately, he didn't recognize her, but she definitely recognized him, and her symptoms started shortly thereafter. So triggering event. And then lastly, the anxiety disorders, once again, a mental health condition that sometimes will manifest with mental health symptoms that will bring the patient directly to a mental health practitioner. But other times, in fact, a majority of times, this condition manifests with a physical symptom that brings the patient to a medical clinician. And if you're not clued into this possibility, you can easily miss it. And I've seen lots of patients over the years who had anxiety disorders and nobody knew about. And one of the clues that this is present is that people's symptoms are much less severe or less frequent when they are in what they consider a safe environment. So one of my patients, for whom his home was a safe environment, he had no symptoms when he woke up in the morning at home. He had no symptoms if he stayed home, but if he left home, the symptoms would begin. And in his case, it was stiffness in his neck and shoulders that would get, and later pain that would get progressively worse the longer he was away from home. He was somebody that just, being away from home, being around large numbers of people was extremely stressful because of his anxiety disorder. In fact, it was not really a surprise to learn that his occupation was working in a printing press on the night shift where there was nobody else in the building. And he used to shop for groceries at, all night markets at 2:00 in the morning to avoid people. All right, I'm running low on time here. We're going to talk a little bit about treatment. One of the best ways is just simply to make a list of all your stresses, because you may be surprised at how many stresses. This is both past and present. You may be surprised at the number that wind up on the list. You may find that some of these stresses are coming from similar places, and you may find that you can begin to make a difference. Once you've all got them all written down on a piece of paper, you can pick out a few of them that you can actually reduce. For people that take care of everybody else in their world but don't know how to put themselves on the list of people they take care of, they need to learn self-care skills. And the best way to do that is to block out some time, ideally several hours every week on a regular basis, where you do some trial and error, try different activities that have no purpose but your own joy. And the more you can do that, the better you'll get at it. And once you have that skill, you'll have it for life. And anytime in the future your stress level gets too high, you'll now have something you can do that will bring the stress level down. Relaxation technique and mindfulness meditation are both good self-care activities that you can learn everything you need to know about from the internet, so I won't spend a lot of time on those. For my childhood stress survivors, one of the most important ideas I want to convey is their own heroism in having survived that experience. The dictionary definition of a hero is somebody who's overcome a difficult challenge, either mental or physical, for a good cause. And people should look at their ACEs experience as the moral equivalent of having been born in a dangerous wilderness that they have somehow managed to survive through their own heroic perseverance. And if they can look at themselves in those terms, it's a huge change in their self-image that's fundamental to making progress with some of those other personality traits that I listed. Writing is another good technique for taking some of those negative emotions and putting them onto a piece of paper or a computer screen. The more of those emotions that you can express in words, the less they need to express themselves via your body. These are some writing techniques. For ACE survivors, one of the most common that I use is writing a letter, not to mail it, just to write it to the people who mistreated you as a child, and putting all your thoughts and feelings down on a piece of paper or a computer screen. And it's can be very cathartic for people, let's put it that way. Fortunately, nowadays, we didn't have this when I was starting out, but fortunately nowadays we've got lots of books and even computer apps that people can use. So for my patients who like to read, this was my first book. Basically consists of 4 dozen case histories that illustrate the spectrum of stresses that can make people physically ill. More recently, a textbook for professionals, but we spent a lot of time taking the jargon out of it. So if you consider yourself more of a science-oriented reader, this is going to be perfectly accessible for you. We took the medical jargon out so the mental health professionals could read it, and vice versa. So it ends up actually being in plain English. And the royalties from both books are donated to the PPD Association. I don't take any money for this work. The Curable app has been available now for almost 5 years, and it incorporates a lot of the new research-based concepts in psychotherapy into a very usable format. And those are some other books that, again, are evidence-based. This is our nonprofit website, endchronicpain.org. Our mission is to teach healthcare professionals and the public these concepts so that patients can improve. We're talking about probably 40 million Americans that suffer from PPD. So there's very few healthcare professionals who know how to diagnose and treat them at this point. So we've got a lot of resources on the website. And then finally, if none of those is sufficient, there are some new psychotherapies out there. Not too many practitioners have learned these. They're still fairly thin on the ground, the number of psychotherapists that know how to use these, but the research is showing that these techniques are superior to the more widely available forms of treatment. And the difference that these have compared to others is that they intend to alleviate central pain. There's a focus on central pain with these or PPD. The goal is relief, not merely helping people to cope, and that it incorporates ACEs, trauma, and emotions into the treatment program. Anytime you have a speaker who is talking about ideas that your own physician may not be aware of, you want to be sure that there's been some actual solid research behind it. And this is one of the recent studies just published last September of people with back pain, and shows the pain scores on the left-hand axis over a full year. And the blue line shows the pain scores dropping dramatically in comparison to the 2 control groups in red and black. And this was 8 sessions of something called pain reprocessing therapy. It is the largest drop in pain scores ever seen with a psychotherapeutic technique. And we're beginning to see a lot of those studies coming out now. This is a second form of treatment, emotional awareness and expression therapy. The idea being that these buried emotions that people have need to be consciously recognized and then put into words. And this technique also has been subjected to randomized controlled trials. And in this one, the control group was cognitive behavioral therapy, which is the most widely available form of psychotherapy. And you can see that the emotional awareness and expression therapy was far superior in the percentage of patients that achieved at least 30% relief of their pain. We don't have time today to go into all these but these are 2 more trials that essentially show the same thing, that when you pay attention to emotions, you are going to get much better results. Let's see here. And just one of my favorite groups here, and this is my last slide, is a group of family doctors in practice in upstate New York who were doing integrated care with a psychologist, and they took the training that's in the online course on the endchronicpain.org website and transformed the care of the 40% of their patients that had PPD, which is a typical proportion, from very frustrating to very rewarding. And one of the doctors took me aside at this conference and said, these ideas have put the joy back into my practice. So I'll stop there. And I think Bill had mentioned taking a 5-minute break. Happy to do that, and then to answer your questions. Thank you very much for having me this afternoon.
Okay, that's been great, and you are right on target. And let's take a 5-minute just stretch or break, and come back, and because I've seen about 7 or 8 questions in the chat, and we'll go from there.
Good. That's
Okay.
But I think it's a good subject.
Okay,
Yeah,
I see David Clark is back. It's been about 5 minutes. So, Rebecca, have you got some questions you want to go through on the chat, and we can get started?
Yeah, okay. Hi, Dr. Clark. Thank you so much for your talk. It was very interesting. Rory asked, how can you tell if you're not interested in activity because of the physical limitation versus not being interested because you're depressed because you have the condition?
Yeah, that could be a challenge to sort out, but I think one thing to look at would be whether your motivation to do the activity is that's the only one that you're affected by it, or if your motivation for a much wider range of activities is affected. So I think the wider the range of activities that you feel unmotivated for, the more likely depression is playing a role.
Okay.
If it's just walking around the block, but you're motivated for everything else, then I wouldn't be so concerned about depression. But if you're finding that your motivation for eating, walking, watching television, playing games, calling your friends, on and on and on, the longer the list of things you feel unmotivated for, the more likely depression is playing a role.
Okay.
Okay, Rory, were you back? Rory? I'm just making sure he was back, came back.
Oh,
Okay.
is he not here yet?
I'm not sure.
Who? Rory. Oh.
We still have 38 people, so okay, anyway. All right, go ahead. That's fine. I was just curious.
Okay, maybe he can repeat it again later.
Okay.
Dr. Clark can repeat it again later. Someone asked, are neurologic pain and central pain the same thing?
Neuroplastic pain.
Yes, they are.
Thank you.
Neuroplastic pain?
Yes.
Sorry, I left out the E, but it's neuroplastic pain.
Yeah, no, I saw that one. Yeah, neuroplastic pain, central pain, those are synonyms. Nociplastic pain is another one.
Okay, thank you.
And then if it's, I use the term psychophysiologic disorders if we can identify a link to psychosocial stresses.
Okay, and those were the only 2 I saw. And if anybody else has any questions, raise your hand and we can address them. How can we find primary care doctors who are using your techniques?
Oh, that's a good question. That's one of the missions of the nonprofit, is to try to educate primary care clinicians. I know I gave a talk to the Kaiser Group probably 15 years ago in Washington, D.C. area, but it's a challenge because it's something that they haven't typically been trained in, either in medical school or in their post-medical school residency. We do, on the endchronicpain.org website, have a directory of practitioners, but most of them are mental health professionals, but there are some MDs on there as well. And you can search by state. You can look and see, who there is in Virginia, for example, that practices in this way. We also encourage people who experience improvement through using these techniques to let their physicians know about it. We even have a letter on our website that some experts wrote that you can pass on to your personal physician and say, I use these techniques. They were beneficial to me. You might want to recommend them to some of your other patients who experience this, because, if for every patient that gives them that letter, they're going to have, 2, 3, 4 a day that have these same issues. It's that common. So, if you can educate your own physician about this, there are lots of resources for healthcare professionals now for them to acquire this information, begin to use it with their patients, and it's very rewarding for their practice when they do that. The patients with this condition tend to be very frustrating for physicians. They run out the string of diagnostic tests. They can't find a biomedical explanation for the person's symptoms, and it's very frustrating for everybody.
Okay. Rory did come back. He said he did hear the answer. He just couldn't get himself off mute.
Okay, great.
That's fine. That's good. Does anyone want to raise their hand and be recognized?
As somebody asked, could small fiber peripheral neuropathy be a PPD or just made far worse because of the PPD?
Yeah, there can be overlap there. I think anybody who's diagnosed with small fiber neuropathy, it's worth doing a stress evaluation on that person to see, do they have those stress issues that I've described, and if they do, to treat them, because I think there's a viable chance that their symptoms will improve.
Now, is small fiber neuropathy, is that the same as idiopathic?
Yeah, anytime you have the doctor is using the word idiopathic or cryptogenic, basically what they're saying is we're not really sure what's causing this condition, and in many, not in everybody, but in many of those people, the symptoms are linked to central pain, linked to a psychophysiologic disorder, and at the very least, doing an evaluation for stress is not going to be harmful, and there's an excellent chance that you will find issues that can be treated successfully and will lead to improvement in the symptoms. It's a very low risk diagnostic approach to evaluate for stress. And the problem is that very few physicians have had any formal training in how to do it. So that's why I give talks like this one, is and write the books, and we have the questionnaire to help people assess themselves and see if they recognize themselves in the descriptions of the causes of this form of illness.
Thank you. Does anybody else have any questions out there?
So see somebody who has a known cause for PN, or they strongly suspect a cause.
Yeah.
Might benefit from this simply because it's adding to the total therapy regime that you're dealing with.
Yeah, I mean, you can have both conditions at the same time. You can have a nerve disease that produces a peripheral neuropathy, and you can have a psychophysiologic contribution to the symptoms. If there was any justice in this world, I mean, if you were unfortunate enough to get a peripheral neuropathy from a nerve disease, that would make you immune to getting a PPD at the same time. But I've seen many patients over the years who had both an organ disease, well-defined, readily diagnosed with traditional techniques, but they had a PPD at the same time that was causing either similar symptoms to the organ disease or adding additional symptoms to it. And it was only when both conditions were addressed that the person got the best outcome to their illness.
Can you give an example?
In my own field of gastroenterology, one of my patients had a flare-up of his ulcerative colitis, an inflammatory condition of the large intestine. It was well documented that his bowel was severely inflamed during colonoscopy done by one of my colleagues. And the patient was treated appropriately for that and failed to improve. So he was hospitalized. He was treated more aggressively with more intensive medical treatment, and he still failed to improve. So he was scheduled to have his large intestine surgically removed, which is sort of the final treatment for that condition. But my colleague, who was his physician, noticed that his bowel symptoms had a kind of an unusual pattern to them. Again, that whenever you see a patient whose symptoms are not what you expect, not typical for, not fully typical for the disease in question, then you should consider the possibility that there's a simultaneous PPD going on. And that's what my colleague did. He said, this patient's bowel symptoms are not typical. There might be a stress component going on here. He did another colonoscopy on the patient and found that the patient's bowel had healed under all the intensive treatment that he'd been receiving for the past few months. So that left no explanation for his ongoing symptoms except PPD. So he asked me to see the patient, and sure enough, the patient was coping with a severe stress. He had been sexually abused as a boy by his father, and he was having a tremendous amount of emotional distress over that, now in his late 30s. And when we got him connected with a psychotherapist who was experienced with that kind of issue, his bowel symptoms finally went away. But so it was only when both conditions were successfully addressed that his illness was relieved.
I believe Craig might have had his hand up at one point. Do you have a question, Craig?
Yes. I found a physician in Charlottesville. He's an orthopedist, but he does treat chronic pain, neuroplastic chronic pain. His name is Dr. Keenan. And it's quite a hike from Northern Virginia. So I saw him in person once, and then I've been dealing with him via telehealth. So that's an option open to people in Virginia. There's another one that I found, and they were both from your direct online directory. The one in Front Royal wasn't taking new patients. So I drove to Charlottesville, and it was worth the trip. Wish there were more.
Yeah, we're trying to educate people about this, because it's the benefit of making the correct diagnosis of a PPD is it's just people start improving. I've had patients who've been ill for years, even decades, who have finally made progress once this correct diagnosis is made.
I'm contemplating your letter. I saw your letter on your website to send to my our primary care physician. My wife has been helped so much in the past 3 months by the work we've done in light of what Sarno said and what your book said, that I'm thinking about writing to him, because he's a really, really good doctor, but it's clear he doesn't have any idea I kind of hit it. I said, why don't you read this book? And he said, well, I don't have time for that. And so maybe write him and ask him to take the online course. It serves as a, doctors have to get training every so often anyway, don't they, on that?
Yes, but it's, they don't even have to take the whole course. We've divided it up into parts, and for MDs, even the first introductory part can be a real eye opener.
Anyway, I'm thinking about trying to figure out how to delicately, very delicately, since he's just such a good doctor, and how to step carefully without causing offense, because those who are familiar with me know that bull in the china shop isn't always the right way to perform.
Okay, are there any other questions for Dr. Clark? Going?
Peter's got his hand up.
Peter, go ahead.
You're muted, Peter.
Yeah, look, I don't know, I was in here but did you go over hypnosis, or where some people cannot remember, but through hypnosis it comes out? I forgot.
Yeah, the hypnotherapy has been used in PPD. It hasn't been as formally studied with randomized controlled trials as some of the other forms of psychotherapy that I mentioned. My own experience referring patients for hypnotherapy, or patients of mine who have sought out hypnotherapy on their own, is that it depends a lot on the skills of the hypnotherapist. If you've got a hypnotherapist that's got some really good empathy skills and is able to tap into some of these unrecognized emotions that people have, then the outcomes tend to be more successful. But there's a fair amount of variability to it. So I haven't, because of the lack of research, been able to make sort of blanket recommendations about using hypnotherapy or not. But some people who have tried it have benefited.
Thank you.
Another questions came up. Sharifa asked if has anyone been to a therapist here that they recommend, and I believe you said that was on your website, correct? That they could look up recommendations there.
Yeah, we have a directory of people who have expressed special interest in this field. Again, it's difficult for many in the mental health field to feel comfortable working with people who are physically ill. It's typically not been part of their training, but there are some who have taken it on as a specialty, who have sought out additional information, training, knowledge. They come to the conferences, who read the relevant textbooks, who are comfortable seeing patients who have physical symptoms. And we've tried to gather their names and contact information in our directory. We aren't able to certify anybody's competence. We don't have the staff or the resources to do that, but we try to evaluate people's knowledge and skills as best we can before we list them in the directory.
Okay. She also asked, what should I look for in a therapist if she wanted to go this route?
Mainly, yeah, the most important thing is that you feel heard by them, you feel comfortable with them as a person, you feel like they are understanding of what your needs are, and that you are making mental health progress under their care. Many mental health professionals will give you a sort of a 30-minute preliminary interview just so you can get to know each other a little bit and find out about what the therapist's approach is and see if you feel comfortable with it. If you're not making progress after 2 or 3 visits, it's perfectly reasonable to begin looking for to find another therapist. You should feel like the therapist has enabled you to improve within the first 2 or 3 visits, and if not, this relationship is extremely important. If you break your leg, even an orthopedic surgeon with a horrible bedside manner is probably going to do a pretty good job fixing your leg, but it's not the case with psychotherapy. You really need to have that personal compatibility.
Okay. Pat has asked, can you speak about meditation or mindfulness? And can you do it on your own, or do you need to work with a therapist?
You can definitely do mindfulness meditation on your own. There's abundant information out there on the internet and in books about how to teach yourself those techniques. They're not difficult to learn. You can do them on your own, and it's a form of self-care that you can do for yourself that's very beneficial. It's in and of itself, by itself, it's probably not going to be sufficient to alleviate significant physical symptoms, but it's certainly a good, what we call adjunctive treatment, something that you can add on to everything else you're doing, whether it's the Curable app or reading one of the books or looking at some of the videos. All of these things kind of go into the mix and have some synergies with each other.
Okay, now you said Curable app. Is that something on the, you can put on your phone or something?
You can put it on your phone. Yeah, it's an amazing piece of work. They have taken the best aspects of the scientifically documented treatment programs like pain reprocessing therapy and emotional awareness and expression therapy. Those are, new psychotherapies that are above and beyond the usual cognitive behavioral therapy and acceptance and commitment therapy. The Curable folks have taken PRT and emotional awareness therapy and put it into the app. The website for Curable is Curable Health. CurableHealth.com has lots of really interesting and useful podcasts and other information that kind of goes along with the app and supports it. But the app alone provides a remarkable amount of useful information, provides it in a somewhat personalized way, and a very easy to use interface.
Thank you.
I just want to reinforce, if I can, the fact that the website has this questionnaire. Go through it. Doesn't take very long. Count it up. See if anything just hits you between the eyes, or a lot of little things, because you might be coping quite well with PN and just want to figure out how to redo the other aspects of your life. But hey, something might leap out at you, and it doesn't take very long.
I agree 100% with you, Mike. That's true. Anyway, any other questions for Dr. Clark?
It looks like Joanne has her hand up. And you're
Okay,
muted, Joanne. You'll have to unmute.
Okay.
Joanne, go ahead.
Okay. I'm wondering whether there's any correlation in the type of physical symptoms that people develop and the ACE that's behind it. For example, as a gastroenterologist, I'm sure a lot of your patients are showing those kinds of symptoms, but like, do just as many people have back pain or migraines, or has that been looked at?
Yeah, it's a great question. It's something that all of us in the field wonder about, but I think we have not seen very strong correlations between particular ACEs and particular physical manifestations. Occasionally we do see that. If you suffered an injury at a younger age, sometimes the nerve pathway that carried the pain of that injury to your brain gets reutilized when you have a stress-related pain, and the pain shows up in the same place. Sometimes you can connect the location of the pain with the location of a particular form of abuse. One of the early studies in the field found that, for example, women with chronic pain in their pelvis had a threefold higher rate of sexual abuse compared to women who did not have pain in their pelvis. So that was, a fairly obvious connection there. One of the patients that I read about from another practitioner had pain on the right lower chest area, and that turned out to be a place where her father had placed his hand when he was molesting her as a girl. So it's, sometimes you find those connections, but most often, the ACEs story for somebody with migraines is not distinguishable from the ACEs story of somebody with irritable bowel or fibromyalgia.
Okay, thank you. Steve has a question. Steve Klitzman.
Yeah, hi, doctor. Thanks very much for doing this. I came in late. Two questions. One, I assume there's nothing in your practice experience to address the numbness issue that we cope with. Many of us have just numbness. We don't have PN pain, and there's no medicine for it because the nerves have degenerated. So I assume there's no psychological analysis or approach or therapy that would make the numbness feel less numb. That's the first question. And the second question is reimbursement by Medicare or Blue Cross. Are your services reimbursable in any event, in any way?
Yeah, there isn't at the moment a diagnostic code for psychophysiologic disorders that would, insurance companies and Medicare, Medicaid are responsive to, but we just work around that by using the term that best captures the nature of the patient's symptoms, whether it's irritable bowel or peripheral neuropathy or pelvic pain, and those are absolutely reimbursable. And actually, there's extra payment if you involve some diagnostic or some behavioral counseling, for example. And there's even a code for child abuse late effect. So if a person has a long-term impact of ACEs, you can use that code for it. For your first question about numbness, as I mentioned at the very top of my talk, there are people who have nerve damage that produces numbness without pain, and my entire talk will be completely irrelevant to that situation. But it's also possible for numbness to be a psychophysiologic disorder. And the more of these issues that I described that you're struggling with, current life stresses, lack of self-care skills, long-term impact of ACEs, mental health conditions that are manifesting physically, it makes sense to address those. And in some cases, the numbness can improve. It's very difficult to predict, who's going to experience that improvement and who isn't. If you've got, nerve conduction studies, for example, that are significantly abnormal, that makes it less likely that a psychological approach is going to work. But it's still, if you answer yes to a lot of the questions on that questionnaire that's on your website now, then there's no harm in pursuing the treatment for those. And there is a possibility that the PN symptoms will respond to that. Even if they don't, these are still good things to pursue on a purely mental health basis.
Thank you.
All right. Anybody else?
Any other questions for Dr. Clark?
Well, if there's no more, we
well,
certainly want to say thank you.
I was going to, what I've seen was that the pandemic had completely exhausted the nation's supply of psychologists and counselors. The demand has been just overwhelming, and their treatment for these kinds of conditions just collapsed. Instead of once a week, you could get once every 5 weeks or 6 weeks. But the point is that we're in an environment right now where I experienced in my past when I had depression. I found that in a large insurance company, they claimed they had counselors and psychologists and psychiatrists, but they didn't. You couldn't get an appointment at all. So this is not just a new thing, but the tools, the soldiers we need to fight these battles for us are not there. They're just not there. And I don't know when they're going to become available. So I wonder what's your relationship with the Center for Medicare Studies and the whole concept of what it is to be healthy? And how goes it in talking to the government people who say this is what healthcare is?
Yeah, it's a struggle. I mean, there was a law passed that said that mental health care had to be given parity with medical care, but as a practical matter, the mental health care hasn't really caught up with the medical care in terms of it being regarded as equally important. And the resources for mental health care, just either in terms of payment or in terms of personnel, have been limited. So this is one of the reasons why we've been looking for more scalable options. Not everybody needs a human being to be their provider of mental health. The Curable app is virtually infinitely scalable. The charges for it are on the order of a half hour or 45 minutes worth of human psychotherapist is what you pay, and you get a year's worth of the app with lots of useful concepts in it. But yeah, it's there are not enough mental health professionals, and only a fraction of those, a small fraction of those, are able to provide care for PPD. We're working towards the day when those needs are met, and there's a couple of companies now that are developing online resources, telehealth resources, to provide this care to larger numbers of people. But even they're having to use coaches rather than licensed mental health professionals, again, because they're just not enough. They are trying to train their coaches in these PPD techniques and methods. It's not quite as good a solution as having a fully licensed mental health professional provide the care, but it's it's a scalable option. It's going to provide more boots on the ground, if you will, in terms of human beings who can provide this care. There's a company called Lin Health, Lin Health, and there's another company called Mendy, I think it is Mendy, that are just startups, and they're using coaches rather than licensed mental health professionals. But in this space, that's a big step forward. So it's going to take time. One of the benefits of this work is that it saves money. When you make the correct diagnosis of a psychophysiologic disorder, then you are able to provide appropriate treatment. If you don't make the correct diagnosis, then all you have is endless, expensive, invasive, risky diagnostic tests that people are put through in a vain effort to find a biomedical explanation for their symptoms. One of my patients had been ill with this for 55 years. He came to me before the computerization of records era, with volume 3 of his paper chart that was 3 inches thick. 3 inches of paper chart with nothing but normal diagnostic tests and unsuccessful treatments. I mean, the amount of money represented by that, and that was only volume 3, was just huge. And he was cured in about a month. I sent him to a class that we had at that time for adult children of dysfunctional families, just a small group of 8 or 10 people with an instructor. And he just opened up to that group. He poured his heart out about his physical abuse as a boy. He was 74 years old when I sent him to this group. And by the end of the 8 weeks of the class, he had no further symptoms.
He had neuropathy, or
No, he had abdominal pain.
oh, okay.
But imagine if he had been appropriately diagnosed and treated in his 20s instead of his 70s, how much money would have been sent. So people would have been saved. So the healthcare system is beginning to recognize that it's in their interest to manage this condition appropriately. And I'm hoping we're going to see that in the years to come.
Okay, Joanne, I'll call on you.
Okay, well, I just wanted to say thank you to Dr. Clark for this really informative and interesting presentation. And if anyone has further questions, we can forward them on to Dr. Clark, or you can probably find a contact in one of those websites. But thank you again. And maybe in a few years, you can give us an update on what's going on with PPD in the future.
You bet. That would be great. Thank you all very much for having me.
And I would love to hear what other people's response is.
This is one of the best things we've done. It's very, very helpful, and gives a path forward. And my stepdaughter has used some of these techniques and cured her pain. I'm going to tell her about that letter so she can give the letter to her doctor. And there are things we can do. It's very hopeful. Thank you.
Yeah, the letter, if you look under on the website under resources, there's a section called Communicating with Others, and there's some letters in there for physicians and for your loved ones, and give some ideas.
All right. Thank you.
Thank you, Dr. Clark. Appreciate it.
Thank you very much, everybody.
Well,
Best wishes.
Thank you very much.
okay, thank you.
Thank you.
Thank you, Bill.